So, good morning everyone. Welcome to our first presentation in the 2022. Inshallah, it will be a very nice year with a lot of achievements, a lot of good news, I hope. Today, Dr. Payam will give us a very interesting talk about imaging of postpartum complications. As we all know, pregnancy is a very common disease, let's say, very common physiological state, and it has a lot of complications, and the delivery has like the most important complications, and some of them are severe and even life-threatening. And we as radiologists, we have a very important job to help and to diagnose these things. Some of them are related to the genital tract, to the uterus, and to the surgical, in case of cesarean section, the surgery itself, and some are in other systems like the brain and other things. So Dr. Payam will take us in a quick tour on these complications, and I hope we all have a good time with it. Okay, تفضل دكتور.
Good morning everyone. Today I'll discuss about the imaging of postpartum complications. Postpartum is the period start immediately after the delivery of the fetus and the placenta till 6 to 8 weeks later. During this period, the pregnancy-related physiological and anatomical changes return back to the pre-pregnancy state. And the appearance of normal physiological and anatomical changes that occur during this period, the appearance of the uterine changes, the anatomical and physiological uterine changes during this period may looks like the postpartum complications, and this make the diagnosis and imaging interpretation somewhat difficult and late diagnosis. So obstetrical and non-obstetrical complications are the considerable source of many morbidity and mortality in the puerperal state. So, and we are as a radiologist play an important role in this entirety by many multimodality imaging approaches. We have ultrasound, CT, MRI. The most two important is ultrasound and CT because they are available in the emergency department. And the most important of the ultrasound, transvaginal ultrasound, can exclude or can diagnose many of the pathologies. And the CT protocol, different of CT protocol are used according to the patient's clinical feature and according to the clinician's suspicions. For example, CT protocol at 70 to 80 seconds after contrast administration will be used for most of the pelvic complications like hematoma, abscess. And some modification of this protocol can be used, for example, late taking image at 100 to 120 if there is suspicious of thromboembolism or thrombophlebitis. Also the other, for example, taking the late if we suspect that there is active bleeding or there is intra-abdominal bleeding, we use in the 35 to 40 second and late in the venous phase. Also we can use contrast in HCT for chest to exclude pulmonary embolism. And the using of contrast and iodine is safe during the nursing mother with special consideration for nursing preterm infant because of the absence of autoregulatory thyroid axis may lead to transient hypothyroidism in the infant.
So would you recommend breastfeeding?
It is safe.
Contrast in breastfeeding mothers?
Yes, it is safe, and then it is premature term, premature fetus.
And basically the CT protocols are 30 seconds after contrast injection
30 to 40 seconds.
For arterial.
For arterial to exclude if there is active bleeding.
And 70 to 80 seconds.
For in case of there is most of the pelvic complications like abscess, hematoma.
Which is the portal phase.
Portal venous phase.
And little bit delay like 100 to 120 seconds.
For thromboembolism and
thrombophlebitis.
Yes.
Okay. Good.
So in order to know the postpartum complications, it is important to know some normal imaging finding during the postpartum change. The appearance of the uterus during the postpartum somewhat complex because of the different appearance of the uterus And so the normal appearance of the uterus during the postpartum may look like complications. For example, the uterus during the postpartum, it is normal pre-pregnancy size. So there's 3 stages of uterine involution to return back to its pre-pregnancy size, and it needs 6 to 8 weeks. We have 3 stages: early, middle, late stages. And the maximum or the rapid change occur in the first 24 to 48 hours, which is there is reduction in the size of the uterus by more than 50% of the size. During this period, the uterus becomes contracted and causing a decrease in the blood loss, and the endometrial line sloughed off as lochia or blood clot. So it's important to differentiate the normal postpartum uterus to the complication. During the postpartum, it is normal to see the enlarged uterus with there is heterogeneous content within the endometrial cavity, and thickened endometrium up to 20 mm is normal. Also increased vascularity, 20 mm.
20 millimeters post-delivery.
Post-delivery, it's normal.
Of the uterine cavity.
Endometrial cavity, yes.
Endometrial.
Up to 20 mm is normal in the presence of any sign symptom to the patient. Also, this is echogenic endometrial cavity with their presence of heterogeneous blood clot within it is considered normal, should not be mistaken as complication. Also, during the postpartum, the engorgement of the veins and arteries. Enlargement of the both ovarian arteries. So there's both ovarian artery are enlarged, with also the the right ovarian vein become enlarged, dilated. Also there is uterine arteries become dilated and more prominent. This is sagittal section of contrast enhanced CT, show that there is hyperintense or hypoattenuating mass within the endometrial cavity. This is remaining of blood clot is normal. Also increased vascularity and enlarged uterus with the presence of a gas within the endometrial cavity up to 3 weeks is normal in the absence of any other clinical feature. These are axial section of contrast enhanced CT, show that there is a hyperattenuating content within the endometrial cavity, indicate that there is blood clot. Presence of a gas is normal up to 3 weeks. Also, there is the archoid artery in the funda has become dot-like appearance, more prominent and enlarged. Also, there is a prominent artery in the broad ligaments, dilated, is also normal. This is a sagittal section of contrast enhanced CT, show there is enlarged uterus with there is asymmetrical contrast enhancement of anterior wall, indicates site of placentation. It is normal, should not be considered as a complication or abnormality. Also, there is a small defect in the upper uterine fundus. The upper uterine fundus indicates site of placentation.
So, gas in the uterus, in absence of signs and symptoms of disease, it's normal up to
3 weeks.
3 weeks. Okay? Good.
And in addition to these changes, there are some other changes that are related to the cesarean delivery. In the first days after delivery, the post-operative imaging findings also may look like complications, like for example, hematoma may look like hematoma or abscess formation. So it is important to know the normal change after cesarean delivery. This ultrasound image shows there is hypoechoic area at the lower anterior uterine segment at the site of the hysterectomy due to edema, as a result of the edema to the side of cesarean section it's occurred. Also, the suture material may appear as a hyperechoic, multiple hyperechoic curvilinear shadow. Axial sagittal contrast enhanced CT show there is linear hypoattenuating non-enhanced area at lower anterior uterine segment. This is the site of the hysterectomy, the site of previous of the cesarean section. Look for the enlarged uterus, it is a normal appearance, should not be misdiagnosed as uterine dehiscence or uterine rupture. Also, this sagittal image of contrast enhanced, so there is hypoattenuating linear area, non-enhancing in normally enhancing uterus. Also, bladder flap hematoma, I will discuss later on. Bladder flap small bladder flap hematoma up to 4 cm is considered normal or non-significant. Also, there is high attenuating content within the endometrial cavity, indicate remaining blood clot, it's normal. In the absence, in most of the situations, we depend on the patient's clinical feature in the absence of any other, because maybe there's overlap between there. Also, this is axial contrast enhanced. There is hypoattenuating linear non-enhancing area in the anterior uterine wall, indicates size of hysterectomy. Also, there is a small hematoma and sometimes periuterine changes like free fluid, few cc free fluid collection and fat stranding or haziness are considered normal finding. In postpartum complications, we have obstetrical and non-obstetrical complications, and because the pregnancy is somewhat complex hormonal changes and the woman is more like to many complications, one of the most important is postpartum infectious. Infection to the postpartum infections, including the genital tract from the uveitis, cervicitis, endometritis. Sometimes these may have no any imaging appearance, so become late in the diagnosis, and the patient may present with the abscess or complication due to spread by lymphatic and venous system spread upward and causing pelvic inflammatory disease. It is sagittal contrast enhanced CT show that there's thick, this all the endometrial node, this thick heterogeneous endometrial cavity, endometrius, with there's hypoattenuating shadow within it, indicate endometritis with increased vascularity. However, endometritis have non-specific appearance, depend on the clinical feature of the patient, more on the imaging finding, because it's non-specific imaging appearance.
So without the clinical complaint, this could be normal.
Yes.
Without history, without fever or pain or
so
things like to refer us to endometritis.
In any
this can
situation.
be considered normal because the endometrium is, I don't know, about 20 millimeter thick.
It's all endometrial cavity.
No, this is the endometrium.
No. This is all the endometrial cavity.
Arrowheads.
The heterogeneous enhanced arrowheads indicate that there's
heterogeneous enhancement of the uterus. Well, the endometrium is this one, and it's thick. Okay, it's hypodense, indicating edematous changes.
Yes.
So, in absence of clinical complaint, this can be considered normal. But with the presence of complaint of pelvic pain and fever, this is highly suspicious for endometritis.
Consider this is all the endometrial cavity. According to this. This is the pyoma. This is abscess or pyoma within the endometrial cavity, and this so it's somewhat difficult. It is challenging to differentiate between them in the absence of any clinical history. On ultrasound, also there is heterogeneous diffuse enlarged endometrial cavity. There is subserosal hypoechoic rim, with there is difficult to differentiate or loss of the endometrial myomaterial junction. This indicates endometritis. Also, this case of endometritis with the retained piece of conception within it. This is endometritis with retained piece of conception. About thromboembolic complication, pregnancy is a prothrombic state, and this increases the risk of embolism to the patient gradually and become management during the late pregnancy and during postpartum period. We have thrombosis of deep vein thrombosis, pulmonary embolism, and others. This axial contrast enhanced show that there is bilateral deep vein thrombosis. Look for the enhancing wall with the absence of flow within it. This indicates thrombus within it. The left leg is more liable for thromboembolism, and mostly at the iliofemoral area. This whole
Right.
left.
Okay.
I'm like
I'm not sure. I'm not.
on the ovary right side, ovarian vein
The
thrombosis.
ovary right
Yes.
side more.
And this is contrast enhanced sagittal image. So there's thrombus within the inferior vena cava and the enhancing wall.
The whole IVC is thrombosed here.
Yes.
And you have to be sure that this is at venous phase.
Of
If
course.
you see this
As I
appearance in the
said
arterial
before.
phase, that's normal. But if you are in the venous phase, like around 100 seconds after injection, then this is abnormal.
Yes, as I said, for thromboembolism to extrude thromboembolism, we take a delay image at 100 and 120 seconds. Ovarian vein thrombosis, in 90% of cases you have bilateral ovarian vein thrombosis. At 10% of them there is unilateral thrombosis. And the right ovary is more prone to thrombosis because of the dextroversion of the uterus during the pregnancy and because the enlargement, normally enlarged right ovarian vein than the left side, and there are many non-functioning valves. Also, the right ovarian vein is more prone to the ascending infection with the protective mechanism of the left ovarian vein, that there's retrograde flow of the left ovarian vein that protected it against thromboembolism. And however, ultrasound is somewhat difficult to diagnose because of the presence of bowel gases at this point, at this area. Here the ultrasound showed that there is dilated tubular structure, then with absence of the flow lateral to the IVC. This is complete thrombus of the right ovarian vein. Also, this is sagittal contrast enhanced, show that there's enhancing wall, coronal section. There is absence of the flow, or there is hypodense area within hypointense area, multiple hypointense within the vein indicate thrombosis. Another case of thrombosis, coronal image. Thrombosis of there is a tubular structure extend from the right pelvic to the right lower abdomen up to the infrarenal of the inferior vena cava. Show that there is absence of the flow within it and indicate there is complete thrombosis of the right ovarian vein. This is another case of right ovarian vein. This is the left ovarian. Left or right? I'm not sure this one. Absence of flow and presence of hypointense area within it. Also, there is dilated non-tubular structure with the presence of thrombus. This patient presented with a palpable mass at the right iliac fossa. Indicate there is the mass completely is a thrombosed right ovarian vein.
So it can be really big, even palpable.
Yes. HELLP syndrome, it's belong to the thromboembolic complication of the postpartum period. However, eclampsia and preeclampsia present during the pregnancy within 30 to 34 weeks, but 20 to 30% of cases may present during the postpartum period, and the patient may present with epigastric pain, headache, or vomiting. Consider the liver. The liver on ultrasound become enlarged.
This HELLP syndrome stands for what? HELLP?
Hemolytic.
Liver.
HELLP. H is hypertension. L is low platelet. P is
Low platelet.
Low platelet.
platelets, elevated liver enzyme.
Liver enzyme. So patient on ultrasound, the liver become enlarged, mainly the right lobe of the liver, and there is heterogeneous or anechoic area indicates subcapsular hematoma. Axial section of native CT, and this is contrast CT. On native CT, there is hyper-attenuating subcapsular area, indicate subcapsular hematoma. In contrast enhancement, there is hypo-attenuating area, indicate also.
So there is bleeding in the subcapsular region.
There is a bleeding.
Due to low platelet count.
Yes.
It will bleed. Okay. Without contrast, the blood will be dense. Okay. While with contrast, the blood will be less dense or hypodense. Okay?
Also, this is a native study and this contrast enhanced study show there is a wedge-shaped area indicates site of bleeding to the liver. On contrast enhanced CT appears a multiple appearance enhancing area
So
in consider to the normal liver parenchyma. This is infraction. Infarction.
Multifocal
Infraction. This is the previous is hematoma. This is infraction. Cerebral sinus thrombosis also belong to the thromboembolic complication of postpartum period, and however most of the patient present within the first 2 weeks after delivery, and the patient may present with headache, visual disturbance, or any other neurological symptom. On contrast, the venography. This is sagittal hull axial section venography shows there's absence of the flow in the anterior portion of the superior sagittal sinus. So on contrast enhancement appear as a hypo attenuating area, and on MRI direct visualization of the thrombus can be seen, and also if there's affected the sagittal sinus appear as a empty delta sign. This is in non-enhanced CT appears a hyperintense area called cord sign.
So this is non-contrast.
Non-contrast CT.
Negative, and you can see the thrombus as dense filling defect within the sinus. We said without contrast, the blood will be dense. With contrast, will be hypodense. And this is with contrast. You can see the filling defect here, and this we call it empty delta sign. Okay.
This is MRI, contrast enhanced MRI direct visualization. This is the thrombosis part.
I don't think this is contrast enough. This is T1 plain.
T1 is
Plain T1 without contrast. And blood on T1 is hyperintense
yes.
on the subacute stage. Okay? So this is subacute thrombus in the superior sagittal sinus.
Also,
okay?
there is
in the T2, you can see
infarction, and sometimes causing infarction and hemorrhage within the brain parenchyma, not only the thrombosis.
Yeah.
About hemorrhagic complication, we have primary and secondary complications. The primary that occur within the first 24 hours, and the main cause of both primary and secondary complication are retained piece of placenta, trauma to the lower genital tract, uterine atony, and uterine rupture. Uterine atony, it means that there's absence or there's failure to the uterus to be contracted, and because as I say, the contraction causing decreased blood loss. So absence of contraction due to either over distension of the uterus during the pregnancy, either due to multiple gestation or polyhydramnios, or maybe due to during the labor, for example, excessive oxytocin to the patient, or maybe due to obstructed labor. And sometimes due to presence of lesion, for example, large fibroid may cause defect in the contraction, or there is a cervical carcinoma. So uterine atony, because there is no contraction, so there is continuous bleeding to the endometrial cavity. This angiography shows that there is extravasation of the contrast material, and this is the bleeding after embolization of the uterine artery, stopping of the bleeding. Also, this is axial section of contrast enhanced CT at arterial phase and at venous phase. For example, there is extravasation of contrast into the uterus cavity, become more on the venous phase because of the normal physiological low pressure within the venous system, and also in the late phase become more appearance of continuous bleeding. This is due to uterine atony. This is a balloon injection. Balloon there is inserted within to the endometrial cavity filled with water in order to as a conservative treatment for uterine atony. This is all the bleeding, and this causes stasis of the bleeding.
So to make something like compression,
yes,
they put a Foley catheter, inflate, and it will press on the endometrium, stopping the bleeding.
This is a large hyperattenuating mass or blood collection within the distended vagina because of continuous bleeding, and this is the cervix. This is the vagina, and this is the cervix, presence of blood within the vagina due to continuous bleeding. And trauma to the genital tract, either due to instrumentation or due to extended labor. And for example, this is gross photo of trauma to the puborectalis avulsion. Look for this 3D ultrasound. Show there is the normal left puborectalis muscle. This is avulsion or tearing of the puborectalis muscle. This is MRI. This side is normal, and this is avulsion and tearing on the right side. On MRI there is signal intensity and abnormal signal intensity present within the tearing or avulsed area. This is the normal. This 3D ultrasound, yes, this normal, and there's avulsion. This is the hypoechoic area, normal puborectalis muscle. There is avulsion of it. So during avulsion or tearing of these muscles lead to collection of blood within the paravaginal area. So in relation to the inferior rectus levator ani muscle, we divide either to infralevator hematoma or supralevator hematoma. Infralevator hematoma mostly diagnosed during vaginal examination, gynecological examination, while supralevator, because it's somewhat deep and may lead to delay in the diagnosis of it, and patient may present with the abscess or shock. So at that time, in most of the cases, present with supralevator on imaging finding with supralevator. And this is the normal anatomy in order to know. This is the levator ani muscle. Any collection below to it consider infralevator, and any collection or abnormal signal intensity above it or collection again and supralevator.
So the problem with supralevator bleeding is that it's usually diagnosed late.
Late, yes.
Why?
Because
it bleeds into the retroperitoneum.
Yes.
So it keeps bleeding internally.
Extend
And-
upward.
Yeah, and no one can feel anything, but just the patient presents with shock and severe like hypotension.
There's delay in the
and things like that.
diagnosis of it. This is T1, and this is T2, I think. Axial and coronal image show that there is this is a normal side. This is left side is abnormal. Look for a comparison in the abnormal signal intensity in the left puborectalis in the levator ani muscle, and this is also the normal side is abnormal side. After 6 months, there is decrease in the side of edema, and also there is subtle immediately normal side after taking the MRI. Normal, the right side is normal. Why? After 6 months, when the edema is decreased, there is subtle tearing of the right side also.
So both sides are
Tearing, but
severe on the
left side.
and very minor on the right side.
This is coronal image, so that there is no tearing, just edema to the levator ani muscle. There is no any tear, just become edematous and abnormal, or we can say abnormal signal intensity, and surrounding also edema or fluid may be seen. This is a distended vagina with a large hyperattenuating mass that the posterior wall of the vagina cannot be seen because they consider or at surgery confirmed that there is tearing of the posterior wall of the vagina. So this collection or hematoma arising from tearing of the posterior wall of the vagina.
So this whole thing is a vagina
Yes,
filled with blood.
blood.
Nice.
And this right paravaginal hematoma or a mass, soft tissue mass at the right paravaginal area at the site of the episiotomy, and led to collection of the blood and ascending to this area.
So this is infralevator.
Infralevator at the site of the episiotomy. Abnormal placentation and retained piece of conception. So abnormal placentation is the main cause of retained piece of conception and postpartum bleeding. We have 3 types of abnormal placentation. placenta, accreta, incerta, percreta. Accreta just the placenta attached to the myometrium, not invading it. While in placenta, incerta invading the myometrium, in percreta invading all the structure, all the layers of the uterus, and also invading to the surrounding structures. In order to know what we see on abnormal placentation, is important to see that these are the normal placentation. Presence of retroplacental hypoechoic area on ultrasound is very important to exclude abnormal placentation. Also on MRI, especially on T2 MRI, presence of trilayered area, hypointense area with their central hyperintense area due to vascularization. This is normal finding. Any disruption of this trilayered appearance on MRI, consider abnormal placentation. Also, this is the normal appearance of placenta. In case of placenta, this is a case of placenta increta, show that there is disruption or loss of the retroplacental hypointense zone. This is very important to diagnose abnormal placentation. Also, in case of abnormal placentation, the uterus become abnormally or asymmetrically bulging, with there is abnormal vascularization of the placenta and presence of multiple dark area within the placenta, and vascularization also be distorted. This is placenta percreta that invade the dome of the diaphragm.
Of the bladder.
Oh, the bladder, sorry. This is the bladder, and this is invading it.
In the image of the left side, just show us the 3 layers, please.
No, this is increta. There is absence of the
Yes,
defect.
but
Yes,
the
the above normal. This is normal,
Which
normal,
one is hyper?
hypo, hyper, hypo. While here there is absence of hypo and hyper.
See, invading.
So any disruption of this trilayered appearance indicate abnormal placentation. This, as I said, abnormal placentation causing retained piece of consumption. There is highly enhancing mass within the endometrial cavity, indicate that there is a retained piece of consumption. Look for the enlarged edematous uterus of the postpartum appearance, with there is asymmetrical in the enhancement, asymmetrical myometrium. This due to the site of placentation. Also, there is heterogeneous has mass within the endometrial cavity, indicate that there is retained piece of consumption.
So retained pieces of consumption enhances.
Enhance.
Enhance.
Enhance. As
Okay.
now I discussed
Retained
the
piece of placenta enhanced,
Yes.
but the conceptus maybe not.
No, the retained piece of consumption, we're talking about the placenta, maybe.
Yes.
Okay.
about retained piece of consumption. It's mean retained part of the placenta or it is membrane within the endometrial cavity, and we have four pattern type of vascularization of retained piece of consumption. Type grade or type 0, there is avascular. The retained piece become avascular, or we can say the meaning of the blood clot rather than retained piece of placenta. In type 1, there is just increase in the vascularity of the endometrium according to the myometrium. While in type 3, there is highly vascularized retained piece and endometrium in relation to the myometrium. So here it is challenging or somewhat difficult to differentiate between the vascular retained piece of consumption or AV malformation. And in case of AV malformation, there is only the myometrium become hypervascular, while the endometrium is normal, or there is no, doesn't cross the myometrium-endometrium junction. Only the abnormality within the myometrium.
Can you repeat it again, please? That's to differentiate between
differentiate,
AVM and retained piece of consumption.
In AV malformation, there is hypervascularity within the myometrium,
Okay.
not within the endometrial cavity.
Okay.
While in a retained piece of consumption, there is vascularization or abnormal vascularization within the endometrial cavity.
So if it's only within the endometrium, it is retained products of consumption. If it is both myometrium and endometrium, this is more in favor of arteriovenous malformation.
AV malformation inside the myometrium,
Yes.
not inside the cavity.
Okay. AV malformation mainly in the myometrium.
Yes.
While the retained products are mainly in the endometrium.
And vascular malformation on ultrasound appears as a multiple cystic area with a highly vascularized, appear as an ill-defined mass with multiple cystic, dilated, and tortuous area with highly vascular. On MRI, it appears as a multiple dark area with loss of endometrial myometrial junction layer. On angiography, it appears as enhancing needles with have multiple feeding artery and early venous drainage. And we have also a congenital and acquired IV malformation. In congenital, we have multiple feeding arteries, while acquired either due to infection or trauma or hormonal change, we have only single feeding artery with single venous drainage.
So it's like AV fistula rather than AV
Malformation.
the acquired one.
And acute, we have acute and chronic complication related to the cesarean section, not to the postpartum as all. And bladder flap hematoma. We know the cesarean section, there is laparotomy and hysterectomy. So any complication related to both of them causing complication. In bladder flap hematoma, there is bleeding at the site of the hysterectomy and led to collection of blood between the bladder anterior inferiorly and between in the uterus superior posteriorly. So this is bladder flap hematoma or collection. And bladder flap hematoma, if less than 4 cm, considered normal, while if they are large, more than 4 cm, it is abnormal, may lead to under necrotic change and may cause abscess formation. This ultrasound showed there is a well-defined anechoic area with multiple hyperechoic or echogenic content indicate that there is abscess formation due to bladder flap hematoma. So bladder flap, if there is less than 4 cm, normal, but if more than it, it's abnormal because may undergo infectious and causing abscess formation. This is sagittal contrast enhanced CT. Look for the edematous uterus. It indicates postpartum uterus, and there is hypoattenuating area between the bladder and the uterus. Indicate this is bladder flap hematoma. Also, this is large bladder flap hematoma between the bladder and the uterus. Again, this is and the site of also there is a site of hysterectomy. Due to bleeding, this collection is as a result of bleeding from the site of hysterectomy. Hysterectomy and cesarean section. And also superficial hematoma. Bleeding to the inferior epigastric artery led to collection of blood between the transversalis and umbilicovesical fascia, and it is important to differentiate between subfacial hematoma and bladder flap hematoma, because subfacial hematoma is extraperitoneal. It is posterior to the rectus abdominis muscle and anterior to the peritoneum. So during the surgery to the subfacial hematoma, they don't explore the peritoneum, they don't open it, while in bladder flap hematoma, they do it. So this is a collection posterior to the rectus abdominis muscle, and here the large collection that compressing the anterior and right wall of the bladder. This is indicate subfacial by anatomy. We can differentiate between both of them. Bladder flap between the uterus and the bladder, while subfacial hematoma between the posterior to the rectus abdominal and anterior to the peritoneum. Also, we have rectal sheath hematoma. This is a contrast enhanced in arterial phase. There is extravasation of the contrast into the rectus abdominis muscle, become more prominent on the venous phase. This is leading to the rectus abdominis. Patient may present with abdominal pain. Look for the large edema, large uterus, indicate that there is a postpartum change. Also, there is a hypoattenuating area with presence of a gas within the rectus abdominis muscle. This is abscess formation. Uterine dehiscence, it means that there is failure of the suturing of the uterus and there is discontinuity between the endometrium and myometrium. How we differentiate? It's important to differentiate uterine dehiscence from uterine rupture. In the uterine dehiscence, the serosa is intact while in rupture there is complete transmural defect within the uterus. And at this point, the MRI, it's imaging of choice or imaging of modality to differentiate between them. In the uterine descent, there is
CT or MRI?
MRI is better.
It's
because
MRI
you're
better.
looking for the cirrhosis.
Yes, we look for the cirrhosis. By the cirrhosis, we can differentiate between rupture and dehiscence. In the uterine, there is communication between the endometrium up to the myometrium with intact cell, intact cirrhosis. This is small hematoma at the site of the cesarean. While in uterine rupture, there is complete tearing or of the uterus, and there is collection. Look for the gas within the myometrium. So there is direct communication between in the uterine rupture. We have direct communication between the endometrium and peritoneal cavity, and sometimes we can see the presence of a gas within the peritoneal cavity due to extension of the gas from endometrium to the peritoneal cavity. There is a peripheral enhancing mass anterior to it.
So you can see the cirrhosis intact here.
Yes.
It's not communicating till here, okay, and stops. While here it's from the endometrium to the peritoneum, complete communication. Open.
And another complication is trauma to the urinary tract. The most common trauma to the bladder, then to the ureter, and most of the time the trauma may be small that we cannot see on imaging finding. Here we have sagittal contrast urography, show there is extravasation of the contrast into the vagina. There is due to vesicovaginal fistula. There is a tract or there is a communication between the posterior wall of the bladder and anterior wall of the vagina. This is the urine extract or going to the vagina due to trauma to the bladder, mostly to the dome of the bladder, and causing perforation or fistula formation. These are about acute complications. On chronic complications, the most common complication adhesion as all the other operations, and we have also abdominal wall endometriosis, iatrogenic seeding of the endometrial tissue outside the endometrial cavity led to seeding in many areas, for example in either subacute, subcutaneous or in the deep muscular layer, and causing abdominal wall endometriosis. Patient present with cyclical abdominal pain. And hence on ultrasound appear as ill-defined well-defined hypoechoic area with internal vascularity, indicate this is abdominal wall endometriosis. On MRI, this is T1. There's abdominal wall endometriosis, become more hyper-attenuating on T2, hyper-intense on T2I. Yes. This is T2 fat sac.
هذا T2 هذا T2 بس هذا التركياتي وهذا فاتسة. So you can see it's a little bit hyper. The thing is here you have to ask the patient, does it hurt more during menstruation or not? Usually endometriosis becomes bigger and swollen and hurts more during the menstrual cycle.
This is the patient present with right iliac fossa mass after on MRI show that there is hypointense mass at the right end of the side of the Cesarean section. So this is the scar endometrioma. About Cesarean scar niche, the other complication of Cesarean section. In scar niche, there is tethering of the endometrium to the myometrium, and this led to fluid collection at this site, and the patient present with intermenstrual bleeding and spotting. So on ultrasound, it appears as hypoechoic area with there is fluid collection. This is the triangular shape or become diamond shape, occur at the anterior uterine wall at the inferior segment. And this is scar defect or scar niche. This is normal myometrium. This is the remaining myometrium over the scar area, and this is the depth of the scar niche, and this is the width of the scar niche.
And by the way, I've seen it.
هو نفس الديهيسنس بس هو كرونيك هذا يسموه نيش.
لا كرونيك لا niche in dehiscence only the cirrhosis are remaining, while here the myometrium remaining over it.
This is atrophy.
Yes.
And
become
I have
thinning.
seen cases where this is a cause of secondary infertility. The patient present with sometimes secondary infertility due to the lesion.
In the dehiscence Sarah, there is the myometeria, it's not remaining, just serosa remain. While in scarnage, remaining, but thinner than the other area because of the site of the scar. We have different shapes, for example, linear shapes. Scarnage, this is triangular shaped, and this is irregular rectangular shaped scarnage. Another chronic complication is ectopic scar or implantation of gestational sac at the site of the previous scar. So it's somewhat difficult to differentiate between whether it's low-lying gestational sac or Cesarean scar. We can use sometimes this rule to differentiate between them. In the absence of gestational sac within the endometrial cavity and positive pregnancy test and presence of this gestational sac here, we draw an imaginary interrupted line. This is the imaginary line, the interrupted yellow line, divide the uterus into two portions, and another imaginary line from the fundus, connecting the fundus to the cervical os. And if the less than 2/3 of SID, superior inferior dimension of the gestational sac, less than 2/3 of it above the blue line, it indicates that this is a scar pregnancy. We do draw this line, the gestational sac. If less than 2/3 of this line above the blue line,
More than
less than.
هذا cesarean scar.
Yes.
بس هذا more than 2/3.
If there's less than below this line. So
Below the
below
line.
the
Yeah.
line.
Yeah.
If
So more than 2/3 above the line.
above, yes, next.
Or less than 1/3 below the line. Scar.
Scar ectopic, yes. This also ultrasound image of scar pregnancy, presence of trophoblastic tissue surrounding it. It's more confirming that this is a scar pregnancy, not a low-lying placenta, low-lying gestational sac. Also, this is T2 image, show that there is gestational sac at the site of the previous MRI. Look for this is the myometrium. This presence of trophoblastic tissue.
Threatened abortion? It's low, the baby is alive, and everything looks normal, except it's in the scar. I mean, it's not that easy to differentiate, but maybe the clinical scenario will tell.
Uterine complications after pregnancy occurred, and most of the cases causing perforation of the uterus, and in most of the cases don't appear on imaging file because they are very small and they are diagnosed at the time of performing the procedure. For example, this case presented with severe abdominal pain and shock. There is perforation after the patient undergo elective termination of the pregnancy at 19 weeks gestation. There is a perforation of the uterus with extruded the fetal part outside the uterus. Look, there is the spine and the lower limb of the fetus extruded outside to the uterus. And this case is fine. In others, it's somewhat difficult because they are very small perforation to the uterus. We have non-obstetrical conditions because the pregnancy is a very complex hormonal changes, so it's more liable than the others for non-obstetrical complications like mastitis, biliary disease, appendicitis, urinary tract infection. In case acute peripheral mastitis due to this acute inflammation of the breast tissue by pyogenic infection due to aggregation of pyogenic bacterial at the skin, and if there is a small tear at the skin or due to stasis of the male may cause peripheral mastitis.
اللي على سونار شيء يتفضل. اللي عنده سونار ديوتي 3/9 اللي يعني الحد يتغير.
On ultrasound, mastitis appears that there is thickening of the skin and also subcutaneous tissue. Look for the fat strand to become more echogenic and enlarged. Also, there is abscess formation behind it where there is well-defined hypo. there is anechoic collection behind it, indicating that there is abscess with mastitis. Also, appendicitis, it's more common during the pregnancy. The most common non-obstetrical complication during the pregnancy is appendicitis. However, this patient after delivery presented with right iliac fossa pain, look for the fluid-filled dilated enhancing wall appendix retrocecally, and look for the enlarged postpartum uterine change, this presence of blood clot within the endometrial cavity. Also, the uterine leiomyomas, they say that the uterine fibroids are enlarged during the first trimester and they regress later on and become more regressed during the postpartum period. Sometimes undergo necrotic or complex regression, and this causes complication. This is the case of bicornuate uterus with multiple fibroid. Look for the large heterogeneous submucosal fibroid with the presence of gas and fluid collection within it. This is necrotic or complex regression of submucosal fibroid. And another chronic complication of postpartum period is acute renal injury. Sudden loss of kidney function. It is due to the same pathology as the general population. And the catastrophic effect of acute kidney injury is acute tubular necrosis, acute cortical necrosis due to microvascular thrombosis. And how we can diagnose it on contrast enhanced CT show that there is normally enhancing medulla while the cortex is not enhancing. Absence of enhancement, thinning and absence. In acute form, just there is absence of enhancement.
In acute stage, it's
absence of enhancement. In chronic
stage,
become thinning. And Press syndrome or posterior cerebral encephalopathy syndrome is another complication of postpartum period in which there is due to autoregulatory defect or endothelial injury to the vascularity due to hypertension, occur mostly in the posterior circulation. So it's mainly modality of choice is MRI, but the patient are presented with a visual disturbance or due to neurological symptom, we took a CT in order to exclude other causes. On CT maybe appear as a hypoattenuating area in the posterior cerebral portion. On MRI it's appear hypersignal intensity. Also there is bilateral hypersignal intensity on T2 and flare, and sometimes it cause infraction, which is hyper on T1 and flare and become low ADC. At that time, this case of infraction. But this case of
posterior reversible encephalopathy.
If there is causing infraction of parenchymal infraction become high on T1 and T2, area of high in T1, T2 and flare, and become low ADC. This case of infraction.
It's mostly due to venous causes in this.
Yes, due to venous infraction. The last complication is pituitary apoplexy. Pituitary apoplexy, it means that there is hemorrhagic and non-hemorrhagic infraction to the pituitary gland, and the main cause or the main risk factor for pituitary apoplexy is pituitary adenoma. While in obstetrical period, we can see Sheehan syndrome is one of it. Sheehan syndrome occurs when there is severe postpartum bleeding, and the patient, due to severe bleeding, may lead to vascular necrosis or hemorrhage into the pituitary gland. And the patient present, how we suspect that this case of Sheehan, the patient is hypotension, hypoglycemic, and yes, postpartum also they cannot feed. So the patient is present with this symptom and with the visual disturbance because mainly compressed on the optic chiasma. Her MRI, sagittal T28 axial T28 MRI showed there is a large mass in the pituitary gland with there is fluid to fluid level indicating that there is a hemorrhage compressing mainly on the left cavernous sinus. This is sagittal and this is coronal image. There is large pituitary hemorrhage that compressing on the left cavernous sinus.
So mainly it's failure of lactation and visual
abnormality.
These are the main two things. There is no milk. Why? Due to non-functioning pituitary gland.
Yes.
Pan-hypopituitarism.
Thank you.
Thank you very much. It was very nice. Okay. What do we have here?
Which one is
Subfacial
superficial
or
or
bladder flap hematoma?
which one? This one.
Superficial.
This one is what? Subfacial or bladder flap?
This is superficial.
This is superficial and this is bladder flap hematoma.
This is a bladder flap hematoma here. The hematoma is between
This is
the
the lung.
uterus and the bladder.
And what is this?
What is this?
Vagina.
No.
Fluid.
Where?
The Morrison.
Yes.
Fluid, we call
Large
this a-
hemiperitoneum. This is large hemiperitoneum, not, and this is superficial hematoma.
Again, IVM or let's start with this one.
This is coming to endometrial cavity. It is most probably contains this of placenta or conceptus.
Second is ABM.
Yes.
Yes.
And
This is
what is
A.
IVM. Good job.
The same.
This is a normal finding or abnormal finding?
This is
The same.
Same patient. A and B.
Same case.
first one.
No, the same.
نفس المريض هنسيبه ساجد.
Where's the abnormality?
Uterine rupture or
Yes, uterine rupture. Presence of the gas within the myometrium.
It is not within the myometrium, the left.
شو يعني؟
This is the within the myometrium.
Yes, it's open to the outside.
Open.
So it's rupture.
Here within the myometrium, there's within the peritoneal cavity presence of gas.
Yeah, it's connected with the peritoneum, so it's completely rupture.
The last one.
Is this normal or abnormal? This part.
Normal
what?
placentation.
Sign of placentation.
Like
Very good.
placentation. Good. So we are getting better.
Yes. And what's this?
What's this?
What's the abnormality?
Extravasation.
Rupture of the bladder. Extravasation of the urine outside. Intraperitoneal, yes.
Means
Yeah.
This
Supra or infra-elevator ani?
it is supra. Supra.
Where is the elevator ani here?
This one, the first above.
This is
one.
supra.
first
This is
supra,
supra.
second infra.
This is supra.
Yes.
And this
here?
is infra.
Because this is the elevator ani. And this is infra-elevator.
Thank you.
Thank you very much.
Excellent. Amazing.